Thank you, Maxius, for having us here. And gosh, what an amazing presentation that Brad and Curry just did. It's a nice sunny day out there, so I know it's probably a little bit tougher for you to be in here. I feel very blessed and privileged to be friends with these three up here. And what's even more amazing is that I truly consider them to be three elite clinicians. And so I feel lucky in the sense that when there's a case that I'm wondering what the diagnosis is, I could call up Brad and ask him what it is. And if there's a incision design I'm curious about trying, I could maybe go ahead and text Israel. And if I'm curious about a biomaterial, maybe I'll go ahead and get in touch with Curry Leavitt, okay? And what I found is that was pretty neat is that all of us use BioXclude, but we each independently came together in using it. It wasn't like Brad tell me, you got to give this a try here. So I thought that was pretty neat. And this was so much fun. I mean, I wish we were there again in Heidelberg, Germany. And you saw from the excellent first presentation the versatility of BioXclude. And a lot of it is because of how unique this barrier membrane is. It not only has a cell-occlusive property, but it also is a carrier of growth factors, chemokines, cytokines, all rolled into one product here. And so you can really do a lot with it. And I think that us as periodontists, we should be really proud that we practice evidence-based dentistry, right? Okay? You'll see that if something is successful, often there's going to be imitations or someone copying what's out there that is working. And so you may see another amnion-only product or another amnion-chorion product, but you got to ask yourself, you know, what research is there behind it? And to my knowledge, BioXclude has a plethora of clinical and scientific research, and including histologic studies, to really back up how safe it is and how effective it can be in treating patients. How many of you out here, just out of curiosity, are using BioXclude? Nice, nice. Hopefully more of you will be raising your hand by the end of next week. So the versatility of this is what we truly appreciate with BioXclude. You know, do a lot of extraction site preservation, whether it's on the smaller site like a premolar or a larger site like a molar. And as not every case is straightforward and easy, sometimes we have to raise a flap to access the defect, graft it, and cover it with a BioXclude. Immediacy is a big part of our practice, and sometimes I am doing an implant with BioXclude at the same time, and more often, I'm trying to do my procedures more minimally invasive. And the beauty with BioXclude and doing these immediate implants and a flapless procedure is that it's so easy to just tuck about 1 millimeter underneath the gingival margin, and it does not matter whether or not it is touching the implant surface. And I don't know what's going on, I'm sorry. Well, there it is. Well, sorry, I didn't mean to pass through to that, but you know, I do a lot of ridge augmentation procedures using it alone for some of these ridge augs, and sometimes in conjunction with the collagen membrane, whether it is on top of my collagen membrane or even underneath the collagen membrane. And certainly when it comes to more complicated procedures where I am using a titanium reinforced membrane or a non-resorbable where there is a higher chance for a complication, I won't hesitate one bit to incorporate biologics to reduce the chance of a complication happening. And you saw plenty of cases earlier in the prior presentation with how Curry and how Brad managed sinus complications, whether it was with a direct crestal sinus lift or whether it was with a lateral window sinus lift. And since we are at an Academy of Perio meeting, I mean, I think we should talk about saving teeth. And I truly find that it is harder to do a GTR procedure to GBR because it's really hard often to get that membrane tightly tucked into a small space there. And the beauty is that when BioXclude, when it gets hydrated and its handling property changes, it's an easy membrane to work with to get in those really tight spaces to achieve regeneration. And even so, you could use this BioXclude for mucogingival purposes. I've myself, I've had success with getting some root coverage, but what I find even cooler than that is what type of keratinized tissue I can get with it. And I don't have a picture of a periodontal therapy, but there's also non-surgical periodontal therapy you can use with BioXclude. I think even studies out there showing how effective it is when you compare it to even a Reston. So you know that there are many clinical indications, and there's a lot of versatility with using this. Hence, it's like a Swiss Army knife. I don't have enough time to go over all these indications here. Unfortunately, Brad and Curry did a wonderful job covering a lot of what's up there. But I'm really going to focus on site preservation and, sorry, I don't know what's happening here, and managing complications with peri-implantitis. So this is probably the bread and butter of a lot of what you do in your clinical setting. Okay, nothing I show here is going to be, earth-shattering. But here we are with a tooth. I like to keep it minimally invasive, divide and conquer, remove each root tip individually, put into particulate graft of your choice. And I want to show you a video on how I use this because there is a learning curve to it, but it's really not that hard to use, and it's not that hard to get used to it. So you want to use a dry instrument to carry over to BioXclude dry. The beauty of this is that it's not side specific. Often what I will do is I'll go ahead and I'll tuck it on the palatal or lingual aspect first. And you could use a wet instrument to manipulate it. I use a micro elevator. This is a mini-me. I use it pretty much for everything. And I'll go ahead and tuck it on the buccal here. And this is in real time. Nothing's speeding up here at all. And if you need to better adapt it, you can get additional saline in there. If you have too much fluid in there, you could always withdraw some of that excess fluid with that magical white thing called gauze. And just a little bit more manipulation with it and get that BioXclude well adapted onto native bone. And, again, the physical properties of this BioXclude make it so easy to work with to do that. It does not take a long time. So back to this case here. This is a larger molar site, and I will almost always, when I use BioXclude, use reverse figure 8 sutures. And since the molar is a larger site, I'll go ahead and do 2 of them. Very, very simple thing to do. All you do is make each bite tagging internal to external, and how that makes your life easier is that you have a lesser chance of nicking the membrane and pulling it out of place, because it could be so frustrating when you have everything set exactly the way you want it and then pull it out and then you starting over again. So this is what I love most about it. This is not a challenging case to do, but I think that it's really important for us to be predictable with our treatment over and over and over again, okay? And this vital bone here gave me a lot to smile about. Okay, and so when I think about this, I sort of think about the 4 M's here, okay? I was able to keep this a very minimally invasive surgery, right? No flap was raised. I didn't have to make any additional incisions and chronally advance a tissue and obliterate the mucogingival junction, right? And when I can do those 2 things, I kept it a more simplified procedure, which is something that I like and something that my patient certainly will like. And what you can see there is with the growth factors and the way you treat this case, that I predictably get this mature bone formation. I challenge you to look at it and see if you could see any residual graft particles. So we have good adequate bone volume and we have good quality bone here. This case is very similar to the one I just showed, so I'm not going to go into great detail. The only difference is that I worked on a smaller tooth, a premolar instead of a molar, and did 1 reverse figure 8 suture. So why am I showing this again? Is I want you to look at, as this patient, by mistake, instead of coming at the 1 week post-op, came in at the 4-day post-op. And this is a true benefit of BioXclude. Okay, the way it goes through a patented processing, you're pretty much de-epithelializing it. So on the amnion layer and on the chorion layer, you have an exposed basement membrane. And what this does is it allows for a faster epithelialization and faster, earlier healing. The other benefit with BioXclude is that it is very anti-inflammatory. And so, truthfully speaking, I more so have less patient complaints with post-op morbidity or any type of pain. On top of that, you notice that I left this exposed. This is a bacterial inhibition assay study done. They had 2 other amnion-chorion membranes. They had a collagen membrane. And what you could see is that there is a larger zone of inhibition around BioXclude, even at a distant away from where the BioXclude disc is. And that is a nice feature to have, that antimicrobial factor, because we all know that the mouth is a dirty place. It's a harsh environment, okay? We periodontists as nerds, we know all those periodontal pathogen names, okay? So this is just another added feature you can get with BioXclude here. Not every extraction case is straightforward and simple. This nice gentleman, 96 years old, referred to me for 2 implants. I consulted with his doctor, and the doctor would not let him go off of the Plavix or aspirin. And it's one of those days where I'm just like, okay, I got to make sure that my defibrillator has its batteries, because I'm looking at 96 and health issues, and I'm like, oh, crap. And heck, if the batteries are not operating well, and then I won't hesitate one bit to refer to this guy. We had a good time in Germany. But look, in all seriousness, okay, when it comes to a patient that you think there's a higher potential for this patient maybe not to heal well, I mean, we're quite often dealing with elders, people who smoke, okay? Patients that are on medications that compromise their immune system, maybe they're not a well-controlled diabetic. We want to take advantage of the 300 growth factors that are available in this biomaterial. That's a nice advantage to have to help us minimize any chance of a complication. So here we are. You know, it's quite a mess here. I mean, the buckle's completely missing on number 8, and number 9, I have a small isthmus of bone remaining there. And I'll tell you that this surgery was very challenging because remember what I told you earlier. We were not able to have him off of the Plavix. We were not able to take him off the aspirin. And this was a surgery that was challenging just because of the hemostasis was very, very difficult. If you look here, I didn't even advance the flap to try to even cover the site. I left the BioXclude exposed, and I know I can do that. But if I made an additional incision to get that release to advance the tissue, I mean, I had a hard enough time controlling the bleeding as it was in this gentleman here. And so why I found BioXclude so helpful for this type of case, I mean, this is really not anything different from what you probably see in your clinical setting on a daily basis, is that I needed something that was going to be easier for me to work with in a situation that was pretty tough. I mean, I didn't have to take time to trim the membrane, right? The way BioXclude is with the basement membrane exposed on both sides, it's just not size specific. You don't have to worry about if you place it up or down. And when you're in a situation where you're just trying to get the patient out, I like to do less thinking and more doing. As this membrane hydrates, and in his case in blood, very fast, the physical properties of this membrane change, and it's easy to work with to manipulate and move it around. And the beauty of this is that you probably see on my Instagram account or whatever webinars I may have done, is that I like to fixate my membrane, but I do not need to in a lot of cases with BioXclude. No tacks, no fixation pins, no sutures. If you look closely at this right here, look how close that BioXclude is to the incision margins. Would you dare do that with a non-resorbable? This is so biocompatible. Let's reduce the chances of a complication. 6 months later, patient's still alive, and we have uneventful healing, good soft tissue, and adequate bone volume. And again, I like predictability. Okay, none of these cases are as crazy, I feel like, as what Brad and Curry were showing, but this is procedures I do often in my clinical setting. And I want this predictability where I get this day in, day out. So I talked a lot about building a solid foundation so we could have an implant placed, right? Now we're going to talk about the truth of implant therapy. And if you go into the world of social media, look on Instagram, you see so many cool videos, posts, stories, where you're seeing an implant being removed, explanted, or rescued, and it's always in there with hashtag, this is not my implant, okay? I don't know how that's the case because I could tell you myself that I have complications myself, and if you even look at this up here, this study with Mombelli, 20% of patients are going to have peri-implantitis. I know on Monday and Tuesday, before I even arrived here, I had 10 separate patients that I placed implants on. So you're telling me that 2 out of those 10 are going to have peri-implantitis? I mean, that sort of sucks. And so we want to try to avoid it, and then if it does happen, we should be obligated and do what's best for our patients and know how to treat it. So here's a nice gentleman, and hashtag, this is my implant. I wish it wasn't. I actually looked through his chart, and I saw his records were flawless. I mean, he didn't smoke, 3-month recalls, perfect health. I mean, on all the supplements you can imagine, and I was like, damn it, I just cannot find anything where I could point the finger at him. But, we had some bone loss around here, okay? And these are implants I placed, 5 years ago? And so when we're talking about surgical options, there are really 3 options available. And, for the purpose of today's discussion, as we're talking about regeneration, you probably know that I'm not going to talk about resective therapy, but I'm going to share some cases here where we regenerate and maybe some ponder doing implant removal. I actually polled that. Sorry, I didn't mean to go through there. I polled that on my Instagram, and rightfully so, and understandably, 75% recommended for it to be explanted, but this being my own patient, like Curry said earlier, we try to save our own work as much as possible. So I go ahead and untorque. As I'm holding my breath, I remove the locator, and fortunately the implant did not come out with it. And I went through my decontamination process using an Action implant neutron tip, and like Brad showed earlier, I love the titanium roto brush. I know there's controversy with titanium dissolution, but I'll say in my experience in using it, I have not seen it adversely affect my results. So here it is, decontaminated the best I can. It takes a long time to go around each and every single thread. But what I'll also do is open up a doxycycline capsule, empty it into a small Dappen dish, hydrate it with saline, and make your doxy slurry. As doxycycline is in the tetracycline family, it's very nice to know that there's studies out there to show that BioXclude can be as effective as tetracycline against some of the periodontal pathogens that we deal with. And so decontamination is key, and also keeping it bacteria-free as much as possible is really important. Sorry. So you saw how large the defect was, and I thought that this would be a great opportunity to incorporate a long-lasting collagen membrane with a BioXclude. And here we are. The soft tissue looks good around it. The CT scan looks promising. I could see that I have some bone around the implant, but it's one of those things that I hold my breath until I'm actually in there and I could witness the good bone clinically. I was tapping on it a little earlier like a madman, I wish you could hear it. It was good sound bone. Go ahead and remove the cover screw. And again, I'm so pleased. Vital, bleeding bone, present. And I go ahead and we just retorque that locator back in. And fortunately, I was able to say hashtag, this is still my implant. So this one, truthfully, is not my implant. It was my retired partner. And you're probably thinking, wow, you just threw your dude under the bus right there. But no, I have all the utmost respect for him. He's the most amazing clinician, learned so much from him, and he's been a father figure to me. And because this is one of his implants and also one of my neighbors, I wanted to do everything I could to save this. I was actually in the middle of a surgery here, and my hygienist came in and gave me that look, and I was like, uh-oh. And she told me there's purulence coming out of that implant. And so as soon as I was done with my surgery, she was done with her hygiene. Thankfully, this was a screw-retained restoration. I went ahead and removed it, put a cover screw in, and then just told the patient to come back the next day on my lunch break. And when that patient came back in, you could see that there's a circumferential defect around it. Also lost some of the palatal bone. If you look carefully on the CT scan on the prior slide, that was missing. And I went ahead and decided to proceed the same exact way that I did beforehand, is go ahead and decontaminate, spend a lot of time doing this, okay? We want to provide the proper environment to give us, this patient, every chance in being able to save or rescue this implant. So I pack in the particulate bone, and you see the BioXclude, it just easily drapes right over it. It doesn't matter if it's hugging the adjacent tooth. It doesn't matter if it's touching the implant. You're going to be just fine, okay? And with this membrane being so thin, it was easy for me to get primary closure. And here we are at re-entry, okay? It's one of those, I don't have much time allotted for my uncovering. And so when I knew I was going over in time, it was one of those like, what the, but you know what? In a good way. Where's the fixture? It's like, now I'm unearthing that implant, playing Where's Waldo? And that's always a good problem to have. Us as periodontists, we like too much bone, like too much soft tissue. And so spent the time locating the implant, and I actually went ahead and put the original crown back in. And this is part of the etiology here, is that, you know, she had mesial migration of her teeth, I believe, and we had an open contact there. So she's actually in the process of getting a new crown, but we just got this back for her. She was so kind to even wait this long without a tooth. So again, a situation where we have that bone from where we are able to regenerate that defect. And my neighbor, obviously very happy about this. So on my final case here, okay, you could see this is a pretty extensive history. This patient came in crying, very emotional, a long history with it, and somehow she ends up in my office in Rocky Mount, North Carolina. In this type of case here, I thought that it would be best, given its history, to press a reset button and start over. Very easy to explant if you have access to the internal part of the implant. But look at the defect we have here, okay? Now we're thinking about a ridge augmentation procedure. And if we're going to do a ridge augmentation procedure, you know, let's not forget that we must follow the past principle, okay? Biomaterials is one part of it, but we also must follow our surgical principles to really have the predictability we want in bone regeneration. But this patient, I mean, she's been through so much, okay? Last thing I want to do is further contribute to her ongoing problems. So how do I look at this? I mean, I know a lot of you probably are already incorporating biologics with what you do, right? So let's go for an easier pass here, okay? Why not have biologics incorporated with therapy here? It's already in the membrane. And it's just so easy to work with. I mean, this takes less than 20 seconds to do is drape it around it. You don't have to trim it, okay? And as this was a larger ridge augmentation procedure, I do want a longer lasting barrier effect, because we do know from studies that you get a sustained release of growth factors over the 8 to 12 weeks that BioXclude is resorbing. And so that's why I had a sugar cross-linked collagen membrane here for a longer barrier effect. Got good primary closure, uneventful healing at 1 week post-op. And if you look very closely here, you can see the BioXclude underneath the collagen membrane. Okay, this BioXclude, this amnion-chorion, is very, very, very thin. Okay, you start layering multiple collagen membranes or even added PRF, I mean, that little bit added thickness can make it a little bit harder to close, especially in the maxilla where you can't advance the palatal tissue. Mandible, it's not that much of a challenge, but it's nice to have that feature with a thin membrane, especially when I'm combining membranes. 6-month post-op, I'm very happy with the radiographic bone. Looks good, but we all know that that is meaningless until we have good clinical bone. So let's look at the re-entry. Here we are, re-entry, 6 months out. I would say that's a successfully augmented ridge right there. And more than satisfies what Monhet recommends in having great 1.5 millimeters or greater in buccal bone thickness to minimize our chances of periimplantitis. Okay, remember this patient has had failure over and over and over again. But it doesn't stop here, okay? Okay, look at that defect. I mean, we regenerated the hard tissue, right? I don't know where I heard this, but they say that bone sets a tone, but don't let the soft tissue be the issue. So I'm not going to hesitate one bit to add some keratinized tissue here by doing a free gingival graft and deepen that vestibular depth so that this patient can have better access for cleaning, and I have a better periodontal phenotype for this implant to have a better chance at an increased long-term survival rate. So I hope those cases interested you, but now I'm going to turn it over to Dr. Israel Puterman, as you will be wowed by some of the cases he shows with GBR.
Thanks, man. Good stuff. Thank you, Dr. Kim and Curry and Brad. You saw some amazing cases that they showed with using BioXclude, and what we're going to be doing is looking at more of guided bone regeneration using something a little bit more stable. You talk about the flexibility of using BioXclude, and that's amazing how it folds over on itself, and sometimes you really want that, and sometimes you want something a little bit with more structure, and that's what we're going to be looking at with the laminar plates. So what this is human allograft material that is laminar bone. It's very easily trimmed, so it bends. It's not a hard surface. It bends. It comes pre-hydrated, and there are other brands, I guess, that come, and I've tried them, that come non-pre-hydrated, and then you have to hydrate it, which adds time to surgical time, and something that really becomes a little bit of a pain in the butt. So I really love this one because it comes pre-hydrated and ready straight out of the bag. Has a long-term resorption of 12 to 14 months, so you know it's going to be around a long time, and this is just an example over here of how it looks. Oof, what's with this thing? So that's straight out of the bag. This is a 30 by 40 piece of the laminar bone that obviously you can bend. You'll see it's about 1 millimeter in thickness, and you can see how it'll be cut and trimmed just like a membrane is. It can be done with a blade, or it can be done just with regular scissors. And you just trim it to form exactly your recipient site the way you would with any type of membrane. So what we're going to do is show the versatility of this using 4 different cases that I have, and starting off with a smaller graft and ending off with a minimally invasive graft. Ooh, my bad. So first one over here is Jane, who it's a lower molar that has a moderately thin ridge. I could place the implant, but you can see the facial dehiscence down the facial of the implant. And a lot of these cases you go through and you say, well, am I going to do a big GBR? Am I going to have to lay vertical incisions? Or is there something that I could really just tuck in there that will allow for bone to grow? So that is the beauty of using this, is a 10 by 10 size of the laminar plate. And you can see how it's tucked in on the facial. And I'm using a good amount of particulated sticky bone that it can really create some distance between the laminar plate and the implant. and cover it up with the BioXclude over the top of the implant. And I'm going to do this as a two-stage procedure to get primary closure or near primary closure at that site. Try to keep it as minimally invasive as possible. And I loved John's reference to his, well, you'll see it next slide, sorry. So you can see this is the closure of the site. It's near primary closure. And then at 18 days, look at how that soft tissue heals with that BioXclude right under the incision line. It's beautiful. There's no inflammation, nice and closed. And at 4 months, we have that problem that he mentioned. I love that. That was the WTF problem, right? Where's the fixture? So it's exactly that. It's a good problem to have. Anytime you do a bone graft and you're trying to cover up an implant, whether it be for guided bone regeneration or for peri-implantitis, I think Brad showed a case much like that also. It's amazing. So this is the type of results we can expect to have when we're using good quality materials. So what we do is just trim that bone that's covering the implant and put a standard healing abutment, and we can see the final restoration, that rather than having that buccal deficiency that we would normally have with a deficient ridge, now we can have a well-contoured crown, well-contoured tissue where food's not going to get impacted. So now we're going to look at Brenda here. So Brenda is, she comes in with an implant, obviously that's a little malpositioned, you can call it that. Went to a dentist where he placed 2 implants at the number 7 and 8 positions, and she was not happy with it for obvious reasons. You can see the tissue coming out the facial, the implant coming out the facial aspect. You can see the facial deficiency. And of course, our smile line. And why do these patients never have a low smile line, right? So raise the flap, and you can see how, yeah, that implant that was sticking out, the facial, he really insisted on screw retained access, I suppose, because he definitely had screw retained access, but the apex of the implant was outside the bone. So using minimally invasive technique, just to reverse tools to remove the implants, you can still see the threads in the bone, and go ahead and place a large amount of graft. Always over graft. We all know this. If you just place enough graft as what you're going to want, you're going to end up with not enough. So you can see how in this case I'm using that laminar plate to create that facial plate instead of a membrane. This is serving as the membrane to create that structure. And here I'm using another long-term collagen resorbable membrane to be able to go over the occlusal aspect. Now, I do often use BioXclude for that. It depends on the size of it. Sometimes I'll use both materials, but it's really just dependent on the size. And here's using the rib roast periosseal stabilization sutures. Get my primary closure. And here you can see how it heals after 6 months. So we go ahead, and you can see that there's some still vertical deficiency over there, and that'll be corrected, but I know that it's there. And so now we're planning for the surgical guide with my lab and design the implant positions. But you can see how that's the laminar plate. We have excellent bone. This looks nice and mature. So go ahead and open it up. And here we are. Place 2 implants, still at 7 and 8, but 2 implants, well positioned. Obviously, if we have enough space between them, we're less concerned about the papilla or bone. And obviously, it's a conversation with the patient. There are pros and cons to placing 1 implant with a cantilever. 90% of the time, that's my choice for this. Every now and then, you have a patient who says, you know what, I want to floss, and I don't want them connected. Well, that means they're getting 2 implants. And so with planning, with good planning, we can see that we have 5 millimeters of bone in between the 2 implants. So I'm not as concerned about the bone loss or tissue loss in between. place a VIP CT graft to be able to try to regenerate as much soft tissue volume as we can and get closure. And now you can see that tissue with that VIP CT graft is much more incisal than it was beforehand. So after healing, here we are, got the 2 implants, and there we are with the provisional restoration, and you can see the development of the papilla even between the 2. Just going to give it a little bit of space, give it some time, and that will fill in. So here we have the before and the after with implants actually within bone. So let's move on to this other case here. This is obviously a very significant defect, very big ridge deficiency in the anterior. And this is what you look like clinically. So missing several teeth, long standing bridge. Elderly, she was late 80s, if I recall exactly, late 80s. But you can see how there's the horizontal deficiency and a very significant vertical deficiency. So there's several ways that we could treat this. Obviously, the bigger the graft, we're going to want more stability to the graft membrane complex. And so that's why I use the laminar plates. Really significant amount of bone. And this is a type of procedure where as you're doing it, my assistant kicks me under the table and says, how are we planning to close this? And I say, well, I love that you're calling it we, but I'll do it. So we put the laminar plates, really fold over the ridge, and using the periosseous stabilization sutures, the rib-rose technique, just to hold things down and contain it. And you can see the BioXclude membranes really over the top of it, give some more growth factors, contain any loose particles that might be floating away. And closure was not easy. There's no question about it. That was not easy. But you can see how it was obtained, and you can see the healing of that. So now, look at that ridge that we had, that we did not have beforehand. Now I could place implants anywhere I want to, have my surgical guide, place 5 implants for a new bridge. And here's the final prosthesis. Obviously some pink porcelain, hygienic, it's cleansable. And on an elderly patient with a low smile line, there's really not much need to go ahead and start to try to graft 10 millimeters of vertical ridge over the entire maxillary anterior. But this is where we started, and this is where we ended with this graft. And this is all using resorbable materials. That's the beauty of using these materials. Most of the time on a case like this, we're not using resorbable materials. We're using non-resorbable materials that are much more challenging to work with, often more challenging to work with, and have a higher exposure rate. And when they do expose, then you end up with a lot of graft failure. With resorbable membranes, with resorbable materials, much more resilient to that. So now we'll end it with Paul, who you can see has got a very significant defect. Looking over here, you wouldn't suspect anything. But it's tooth number 9 that has the defect. Still, doesn't really look like much until you look at the CT scan. This is a tooth that obviously had endo a couple of times, had an apico, and now has a recurrent infection. Typically, this is, lay a big flap, a couple of vertical incisions, do a big GBR. But for him, really wanted to try to keep things and minimally invasively. So here's where we started, and I'm showing the after right away. That's the after. How did we get there without even laying a flap? You could only do that with certain materials and by really focusing on preservation rather than regeneration. This is, you could call it guided bone preservation. So here's a little video of the procedure, and you can see how, obviously, I use a microscope, a 3D microscope. So this is the view that I have, and I'll be able to look inside the socket. just like that. And you know, having the microscope is kind of a blessing and a curse. It's a blessing because you can see a ton. It's also a curse because oftentimes I would have given up 10 minutes before, but when you can see it, then you really want to get every little last cell out of there. But because this was recorded, I think it just showed, I'm not sure if it did there, but I think this was 30 minutes long, 30 minutes of degranulation of that socket. 30 minutes. When I didn't notice that during the procedure, but when I was reviewing the video, I saw, holy cow, it took me 30 minutes to fully degranulate that. So you can see I made that vista incision, and now using a structured, very, very stable membrane or laminar plate, I can slide it in through that vertical vista incision and have it tuck over the facial of that obviously deficient facial plate. So create that new facial plate. Then place PRF membrane, place a BioXclude membrane. This is a small area, it's just one single incisor. I have no problem with a BioXclude there, and using the same technique that John showed before, the inside out or reverse figure 8. Get closure. And just leave it like this. There's no primary closure. So after waiting 6 months, this is what we have on the CT scan, and that was what we had before. Obviously, significant regeneration of that defect without laying a flap. The only 15 blade, the only blade that was used for the vista incision. And this is how he looked clinically. So now we go ahead and do more preservation, preserving the papilla, preserving that facial soft tissue margin. I'm using a surgical guide again and a customized healing abutment made by my lab based on the implant position that's being planned. Place the implant with the guide. No destruction of the tissue. Now, because it was a healed site and I have a little tissue punch type of incision, I also now have a little bit of tissue. I could deepithelialize that tissue punch, and now I have a connective tissue graft to further augment the facial tissue. So I slide it in, suture it in place into a little tunnel, a little pocket, and place my customized healing abutment meant to preserve the tissue to be exactly where I want it to be. That's how it looks from the occlusal view. And then once it's all healed, you could see how the tissue is formed nicely around it. There's the implant. Once it's been provisionalized, this is how it looks when it's finally restored. So BioXclude and I might have sent you the wrong one. BioXclude and Maxis, the laminar plate, honestly, they go hand in hand like all of these guys over here. I'm sure Curry likes Starsky and Hutch. Are you Starsky and Hutch guy, or Chewie and Han Solo? Not quite sure. But we use them a lot together. It's all about using the right materials in our hands, like my three friends here spoke about a lot. We have to use the right materials. We're specialists. We're doing a really good service for the patients and using the flexibility of our materials to our advantage. One material is very flexible, one material is very stiff, and use them to their advantage so that we can end up with the best results possible. And thank you for your attention.